Let's talk about the clinical significance of the ADH. Now, the clinical significance of ADH usually comes in two forms. Either there is excess amount of ADH being released into the bloodstream, or there is low amount of ADH being released. Now, the low amount or the excess amount can result in two type of syndromes. Now, the first one being diabetes insipidus. Now, diabetes insipidus is a very different condition from diabetes mellitus. Now, it is called diabetes because it shares two of its symptoms with the diabetes mellitus. Now, those two of symptoms being that it causes polyuria and it causes polydipsia, that there is increased amount of thirst and there is increased amount of urine outflow, and because of this it is called diabetes insipidus, even though both the pathology and symptomology, the extensive symptomology, has nothing to do between the both condition, both the diabetes insipidus and the diabetes mellitus. The other one being the SIADH, or the syndrome of the inappropriate ADH secretion. Now, in SIDH, there is increased amount of ADH secretion, while in diabetes insipidus, there is decreased amount of ADH than the normal limit. Now, it can be easily be remembered through the mnemonic for diabetes insipidus. Now, the mnemonic for the diabetes insipidus can be TD, where both T's stand for dumb receptors or disappeared hormone. The diabetes insipidus usually results from either receptors which are malformed, so they are not coupled with the ADH hormone. So because of this, the ADH is unable to express its effect. So the receptors are malformed. The other one being that there is decreased amount of ADH. So in the first one, even though if we have an adequate amount of ADH will not be able to exert its effect. Why? Because the receptors are not functioning correctly. So dumb receptors or disappeared hormones, both can result in diabetes insipidus. The other one is that it results in dilute urine. So much dilution can occur that usually the osmolarity can be increased for more than 300 milliosmoles per liter. Next is the SIADH, in which the ADH is released in excess amount. Now, it can be easily understood with this mnemonic that there is such an immense antidiuretic hormone secretion. So SIADH, even though its medical abbreviation is syndrome of inappropriate ADH secretion, it is usually the increased amount of ADH which causes this syndrome. So there is an immense amount of ADH secretion. Now let's talk about, first of all, the diabetes insipidus, where the amount of ADH released is lower than the normal value. Now, diabetes insipidus can be of two origins. The first one being the central diabetes origin, where it is actually the hypothalamus that is not producing enough ADH. Or it can be nephrogenic diabetes insipidus, where there's some problem in the kidney which inhibits the expression of ADH in the body, in the kidney's tissue, on the nephron. Now, in the case of the nephrogenic diabetes insipidus, there can be both normal amount of ADH, there can be low amount of ADH, but the important thing at this point is that in nephrogenic, the expression of the ADH on those hormone receptors is decreased. So that is the nephrogenic diabetes insipidus. Now there are two primary symptoms of diabetes insipidus. The first one being there is primary polydipsia. Now, primary polydipsia means that there is increased amount of thirst in the patient. The other symptom is that the patient suffers from increased amount of diuresis, that the patient has both hypotonic and dilute urine that is being excreted out. Now, this is usually known as polyuria. So, both polydipsia and polyuria are two primary symptoms of diabetes insipidus. Now, as for the central diabetes insipidus, it has very usual causes. The first one is that it can result either due to the familial hypothalamic diabetes insipidus, that it is inherited through the families, where the secretion of the ADH hormone is decreased by the genetics. The other one being that it can be due to some kind of tumors or neoplastic reasons. Now, tumors usually account for 30% of all patients which suffer from central diabetes insipidus. It can also be due to trauma and surgery. Now, trauma also accounts for about 30% of all patients suffering from central diabetes insipidus. And surgery is usually brain surgery, which usually either lies close to the posterior pituitary or is performed near the hypothalamus. Both of them can result in hemorrhage, and the hemorrhage then can result in tissue necrosis, which can affect the hypothalamus and its ability to release the ADH hormone. The other one being the nephrogenic diabetes insipidus. Now, it can be due to congenital nephrogenic diabetes insipidus. Now, whenever we're talking about congenital nephrogenic diabetes insipidus, it is usually of two types. The one is where the aquaporin are not expressed properly. Now, it is a mutation in the genes which code for the aquaporin to water channels, or it can be due to in mutation in the genes which code for the vasopressin receptors or the V2 receptors. Now, the only thing that needs to be remembered here is that the mutation which causes the decreased amount of V2 receptors is X-linked, while the mutation in the aquaporin 2 genes is autosomal recessive. Now, another cause of nephrogenic diabetes mellitus is the acquired one. Now, it can be acquired via a variety of different diseases which result in the destruction of the renal tissue. One of the most common problems is the polycystic kidney disease. Now, in polycystic kidney disease, there is a huge amount of cysts present all over the tissue of the kidneys. And because these cysts both inhibit the function of the renal tissue and destroy the renal tissues, there is decreased amount of both the aquaporins and V2 receptors, resulting in reduced expression of ADH on the renal tissue. Because when there is reduced renal tissue, correspondingly there is reduced amount of both V2 and aquaporin 2 receptors and channels. So it can be also be acquired. Another reason for diabetes insipidus is the intake of certain drugs. Now, lithium, which is usually taken from either bipolar disorder, which is a disorder in which the patient suffers an alternating stage of both mania and hypomania, lithium can affect the expression of ADH receptors and aquaporins. Now, dimethylcycline is an antibiotic which is usually given in patients with the SI-ADH. But when it's given as an antibiotic, it can have some effect on the expression and the effect of the V2 receptors, because the way it works is that it inhibits and blocks the V2 receptors. And because it blocks the V2 receptors, the ADH does not properly expresses its antidiuretic effect. So the patient suffers from both polyuria and polydipsia. Now, there is no cure for diabetes insipidus. The only treatment that you usually advise the patient is that they have to go with the symptoms. If the patient is suffering from polydipsia, they have to cure the increased amount of concentrated blood. If the patient is suffering more from polyuria, then certain other drugs are given. But most commonly, the patient usually complain of increased amount of polydipsia or increased amount of thirst in those patients. So what we usually advise in those patients is that we ask them to increase the amount of water that they intake on a daily basis. So usually if a person's intake is 6 to 8 glasses per day, we ask them to increase that by a factor of 2, that they have to double that amount. So they have to ingest large quantities of water. Another way that they can counter this is via excessive IV fluids. Now, this is usually not recommended because IV fluids, even though they can be given easily on a repeated doses, they can have certain dire effects. One being that they can affect on the site where they're being cannulated. The other being that because the IV fluids do not come in pure distilled water, and we usually do not give pure distilled water to any patient, they usually come as either normal saline or hypotonic or in hypertonic nature. Some even come as other type of like Hartmann solution, but over time the extra electrolytes can develop in an excess amount, and because of this, excessive IV fluid intake or being cannulated into the patient can have some very bad or dire consequences. So usually we ask them to change their lifestyle and change their diet and increase the amount of water intake by a factor of 2. Now, whenever a patient performs this function, what happens is that because of the increased amount of water now circulating in the water, there is the blood becomes diluted. Now, because the water has now diluted, the osmoreceptors will detect the dilution and will give the signal to the ADH. And if the aquaporins, and if it's a nephrogenic type, then the aquaporins will start to lower their expression. And when their expression is lowered, what happens is that the patient's ADH levels will start to normalize. Now, ADH levels start to normalize or increase only in those patients which have the nephrogenic type of diabetes, because in those patients the ADH, the expression of the ADH, both channels and the receptors, that can be both down-regulated and up-regulated. And because they're taking large amount of waters, there's down-regulation of both the channels and the receptors. And in the case of the central, this gives a signal to the central hypothalamic tissue to increase more amount of ADH. Now, if the person is suffering from any kind of situation where the tissue itself is being destroyed, this will not result in the normalization of the serum ADH. The patient will still have low ADH in their body, but the symptoms of the diabetes insipidus will be reduced. Now, let's talk about the other end of the spectrum. the SIADH, or the syndrome of the inappropriate ADH secretion, in which the ADH secretion increases. Now, there is a variety of reasons why ADH can increase in a patient. The first and foremost is malignancy. Now, there are many tissues and many tumors which have the ability to produce the ADH or the vasopressin hormone. And because of this, malignancy and sometimes, or more specifically, the pulmonary tumors, or more specifically, the small cell lung tumor, can have increased amount of ADH being produced by them, that increases the amount of ADH circulating in the blood. Another is the drugs. Now, if we take these certain drugs such as carbamazepine, the SSRI, or the selective serotonin reuptake inhibitors, or the amitriptyline or morphine, if they are ingested in larger amounts, they can result in large amount of ADH secretion. Now, any kind of primary brain injury, such as if there's a problem with meningitis or there's some kind of subarachnoid hemorrhage, gives the signal to the hypothalamus to increase the ADH secretion. Hemorrhage is usually a very good trigger to release the ADH secretion. And if that hemorrhage is central, it is found in the brain, then the response to that injury is even more quick. So, if there's primary brain injury, ADH amount in the body increases. It can also be due to certain infections such as pneumonia or cerebral abscess. Again, because of the pneumonia, because the pulmonary tissue is being compromised, there's increased amount of ADH secretion. And in case of cerebral abscess, because of that abscess has resulted because of an infection, and that infection can result in inflammation and hemorrhage like situations, it can result in increased amount of ADH. Lastly, it can be due to hypothyroidism. Now, whenever there is hypothyroidism, there is increased amount of TSH or thyroid stimulating hormone trying to prevent the hypothyroidism. So whenever we have increased amount of TSH, we have increased amount of ADH circulating in the blood. Now, because of all of these situations, the ADH in the blood is found in excess. It is way above the normal limit. And because of this, what we have is that its effect on kidneys is increased. And because of this, the ADH starts to bind with the vasopressin receptors at an alarming rate. And because of this, the aquaporins starts to express themselves in an increased fashion. They are usually found in the endosomes, and when they are expressed on the cell membranes, they are increased in a huge amount. And because of this, they allow water reabsorption from the urine back to the blood, resulting in antidiuresis. So any kind of diuresis or water excretion in the urine is inhibited, resulting in highly concentrated urine. So, because now the urine is highly concentrated and water is being reabsorbed, we have low serum osmolarity and increased serum volume. And because of this, there's a lot of problems that can happen with the patient. Now, one of the common one is because of the increased ADH secretion, there is dilutional hyponatremia. Because of the dilutional hyponatremia, there's decreased amount of aldosterone secretion. So decreased aldosterone secretion and dilutional hyponatremia are two of the most common symptoms associated with the SIADH. And we can cure SIADH in patients by giving them a certain drug known as the temclocycline. Now, demclocycline is an antibiotic, but it inhibits the vasopressin receptors, resulting in decreased amount of ADH expression. So even if there is large amount of ADH circulating in the blood, it will not be able to express itself via the V2 receptors, resulting in decreased expression of aquaporins, resulting in some diuresis. So it can be cured by giving the dose to the patient of demclocycline. Now, because we have given both the demclocycline, urine osmolarity increases and urine volume is decreased. So it returns to normal.